and presentation is clear, I'd appreciate it. The event will start in about 5 minutes. Thank you.
It's on.
Well, good evening, everybody. Welcome to Core Cardiology. This is the fourth of our series of 6 CME programs. Tonight we're going to be focusing on heart failure, and particularly the intersection of heart failure and diabetes, and what a dangerous place that is for patients in your practice. To recap briefly, we started off with Sheldon Tobe with the C-Change guidelines, 61 new recommendations, which seemed overwhelming enough. And then we had Subodh Verma focusing on SGLT2 inhibition, an important new tool in our armamentarium. Last time we had Jeff Healy dealing with silent atrial fibrillation and the importance of how we look for that and how we respond to that. Tonight, frankly, is the hardest medicine of all. Heart failure medicine is unforgiving. It's difficult. When you combine it with diabetes, it's even more difficult. Cancer medicine, nobody gets better in heart failure medicine. Nobody gets cured. The timelines are shorter than in cancer. The prognosis is often always worse than cancer, and the margin for error is smaller. So tonight, Dr. Mike MacDonald is going to take us through that scenario. But we want to acknowledge in advance, we know this is hard. This is going to be the hardest session we have. We want to help you in family practice do this better. We know how hard it is. We're trying to do it better. We know how many resources it takes to do it, even in our setting here, where we have fantastic nurses and we have resources. So we know how difficult this is. We're going to try to develop some tools together, one of which we'll have a look at tonight. This is just a preview of it, which went out to everybody electronically who's joining us by webinar, as well as those in the room who have it in hard copy. We'll talk about it a bit more. We don't have to go over it in detail now. But there are things that we can do to help you. So we can help you design queries within your EMR that will identify care gaps and patients who need to perhaps come to see heart failure specialists or who need to get into the pathway. We can create an electronic version of the flow sheet that I showed you if you think that's going to be of help. And we'll discuss that and try to work with you together to achieve that. On the good side of the ledger, 2 weeks from now, we have Chris Simpson coming to talk about cannabis in the heart, so we can all chill out then. But tonight we got to really be paying attention, because this is difficult and very important heart medicine. So with that, it's my pleasure to introduce Dr. Mike MacDonald. He graduated from Life Sciences at Queen's and went on to medicine in Ottawa, and then trained in Alberta in internal medicine and cardiology. And then he went to UHN for heart failure and transplant medicine, where he's been the director of the program. He's a renowned teacher and educator, which you're going to see in a moment. And he's involved, of course, in the development of heart failure guidelines. And he's very interested in helping family practitioners, whether they're in a rural area or in a big city, implement the guidelines and ensure that their patients get the best possible care for heart failure. So Mike, if you'd like to take over, that'd be great.
Thanks very much for the invitation and for the introduction, and it's a pleasure to come to this venue. And as Dr. Hughes said, it's a lot of heart failure is a lot of heavy lifting. And I think, like a lot of cardiologists, speaking for myself, but probably some of my colleagues, we went into cardiology so we didn't have to stick with things like diabetes and kind of go the other way. And I think it reflects the changing times that we now have to talk about the entity of diabetes as it relates to heart failure, or heart failure as it relates to diabetes. So that must mean we have new therapies, or that must be some cause for optimism. And I think that's sort of true. And you've had a session on the SGLT2 inhibitor story, and I have some of that in the talk here. But really want to focus on one aspect of heart failure that really dogs us, and it contributes to the level of difficulty of looking after these patients. So without further ado, let me spacebar. Okay. These are my disclosures: a mix of clinical trial support, consulting fees, and educational grant support. And I will say that that I'm really interested in the discussion that follows. I'm keen on your feedback. Many of you are involved in primary care, just to let me know your perspective on cardiology land and some of what we're going to be talking about with respect to risk factor management, diabetes, and heart failure. And my academic interest is really guidelines and knowledge translation. So one of the holy grails of what we're trying to do is to disseminate information in a very practical, usable format that translates into more people getting what they need at the right time. So diabetes and heart failure, is that really a thing? Why are we even doing a session on that? I think anyone who's looked after heart failure patients acknowledges or recognizes that patients with heart failure tend to be older. They tend to have complex comorbidities. On average, they've got 4 or 5 serious, potentially life-limiting comorbidities. They have a lot of cardiovascular comorbidities, but in fact, they have a lot of non-cardiovascular comorbidities as well. And COPD, anemia, chronic kidney disease, and of course, diabetes is highly prevalent in just about any population of heart failure patients that you look at. And this number, 25%, is durable across big population studies, clinical trials. So when you think heart failure, think off the top that 25% of your patients have diabetes, and actually a huge number on top of that have prediabetes or impaired fasting glucose intolerance. And why is that a big deal? Well, this is a wonderful systematic review and meta-analysis. It's wonderful because it includes a mix of different heart failure types. It's wonderful because it's new, published within the last couple of years, and includes almost 400,000 patients. And so what this study looked at is the impact of diabetes on a heart failure diagnosis. And again, 25% of patients of the 400,000 had a diagnosis of diabetes. And the presence of diabetes is associated with a significant, clinically significant, statistically significant increase in mortality. And that didn't matter if you had preserved ejection fraction, so an ejection fraction over and above 40 or 50%, or reduced ejection fraction with an ejection fraction less than 40%. Didn't matter if you had acute heart failure or chronic heart failure, whether you were randomized in a study or whether this is observational data. This is a pretty strong relationship. So there's supposed to be a graphic there, but or an animation. But what I wanted to show with this slide is that if you consider a base case of a 70-year-old female with an ejection fraction of 35%, the average age of all heart failure patients is about 70 years old, and women have this just as much as men do. So 35% ejection fraction, some moderate to severe disability with class 3 heart failure symptoms, which means this is a type of patient that can't walk up a flight of stairs very easily, can maybe struggle to make 2 blocks on the level before stopping to rest, has moderate impairment in renal function, and is on reasonable initial heart failure therapy with an ACE inhibitor and a beta blocker. So this probably sounds like a lot of patients you see, certainly like a lot of patients I see. So what is her mortality without diabetes versus what does the mortality look like with diabetes? And something called the MAGIC score is a well-validated, very usable risk score that's available in app form online. You just plug in a few variables and it spits out a very reliable estimate of 1 and 3 year mortality. So I just took this base case and entered the patient's data in the MAGIC risk calculator. And her risk of dying if she didn't have diabetes is about 10 or 11% in the next year, 26.9% in the next 3 years. And that number goes up. The impact of just changing one variable and giving this patient diabetes, you see that in 3 years, there's more than a 1 in 3 chance this patient won't be alive. So as Dr. Hughes said, this is more malignant than most cancers. This has a worse prognosis than most cancers at a population level. So again, this is very telling and supports the meta-analysis data that I just showed you. Looking at it another way, so if you're looking after diabetes patients, what is the prevalence of heart failure in that population? And this varies depending on the population study. This is data from 4.5 million people across the world in registry form. You're looking at an average age of 64 years with a mean duration of diabetes of 10 years. So maybe a typical population-based diabetes study. And about 14% of these patients have heart failure. That estimate goes up as you get older and up to 40% in some series. But what's striking is that we think of the macrovascular complications of diabetes in terms of atherosclerosis, heart attack, stroke, and of course the microvascular diseases as well. But heart failure is more prevalent than stroke, myocardial infarction, or background coronary disease. So and John Howlett, who I guess was here not too long ago, is a close colleague of mine. He likes to say that diabetes is actually the most common macrovascular complication of diabetes. And this is one of the slides that we had crafted in our work in the guidelines committee. And this is Framingham data, old population, famous population study of cardiovascular risk. And what this shows is that diabetes confers greater risk of heart failure than does other macrovascular complications, particularly in women, interestingly enough. So this is 30 years of follow-up. The hazard of developing heart failure is higher than the hazard of developing other macrovascular complications, which is something that never dawned on me in my cardiology view of the world until we started to have to think about diabetes in a meaningful way. So one of the things that is maybe not particularly obvious is that this notion of heart failure, one assumes, is just related to atherosclerosis. You have diabetes, you get atherosclerosis, you have a heart attack, you're at risk, you develop heart failure. But in fact, that's not necessarily true. Certainly in diabetes or in diabetic patients with diagnoses of heart failure, all of these patients have to be evaluated for ischemic heart disease. That's good common sense. I think everybody recognizes that, but there is a clear entity described almost 50 years ago, more than 40 years ago, of diabetic cardiomyopathy, where the coronaries are normal, but the heart is clearly not working very well. Patients have heart failure and they die from heart failure, and that's not explained by atherosclerotic disease of the heart per se. Risk factors, we think, are related to diabetic control, so hemoglobin A1C, albuminuria. And anytime you see a graphic like this in a review article, it means nobody really knows what the cause is, right? So these are sort of throwaway terms, and people spend their life on one arm of this. But there are probably multiple factors that come to bear on heart failure in the diabetic population. So myocardial stiffness is sort of the final common pathophysiologic result of some of these other factors. When we think of heart failure, irrespective of the systolic function, the diastolic function is often related to cardiac stiffness. Diabetes likely impairs myocardial relaxation and creates this stiff heart syndrome. And it may be related to the amount of fat you have around the heart. So obese diabetics tend to do worse than non-obese diabetics. Endothelial dysfunction related to nitric oxide handling and production and uptake. Cell apoptosis, glycosylated end products, and myocardial fibrosis. So these are, I would say, theories or hypotheses that warrant a lot more investigation. And it's hard to know which one of these points represents a target of intervention. So where are you going to intervene with a therapy that's going to change the game so that you don't develop a heart failure phenotype? And if you're reading the small print on this, this is actually the most common phenotype of heart failure. What does it look like? Is heart failure with preserved ejection fraction. So these aren't necessarily the echo reports that come back and say the ejection fraction is 35%. This is actually, the systolic function looks normal. It's 55%, maybe a little bit of left ventricular hypertrophy, left atrial enlargement, sort of the footprints of diastolic dysfunction that you have to be pretty savvy and attentive to recognize. And so I think I would submit that diabetes and heart failure, yes, it's really a thing, and it's a toxic combination. And then the question, of course, is can we change outcomes? And I think the answer is maybe. Interestingly, although glycemic control is probably a risk factor for heart failure in diabetics, achieving tight glycemic control doesn't necessarily change the game, which is a disappointing result from a lot of the landmark studies of macrovascular complications in diabetes. You control blood sugar to get hemoglobin A1C down by 0.5 to 0.5%. You'd expect less macrovascular complications, certainly less microvascular disease. But I think the jury's still out in terms of heart failure as an outcome related to tight diabetic control. It seems, at least in this analysis that is relatively, well, it's 10 years old, it's not that recent, but it seems that myocardial infarction can be mitigated by better glycemic control. And that's known from 20, 30-year-old studies where the more runaway dysglycemia a person has, the more they're likely to have myocardial infarction and stroke. But I think the jury's very much out in heart failure as a consequence of diabetic control. So I think how we get there, or how we try to achieve glycemic control, is the story to tell, at least in 2019, more so than if we can achieve tight glycemic control. So a wonderful review paper by one of my colleagues, Dave Fitchett at St. Mike's Hospital, who's been an investigator in the EMPA-REG clinical trial. And if you look at heart failure outcomes in clinical trials of glucose-lowering therapy, the outlier is in the SGLT2 inhibitors with the EMPA-REG study. And that really gave rise, in part, to this whole idea that we should think about heart failure outcomes in diabetic patients taking oral hypoglycemics. Insulin, probably neutral in its impact on heart failure. Sulfonylureas, metformin, and GLP-1 antagonists, or agonists rather. I'll show you a couple slides on what we think is going on with those drugs and the DPP-4 inhibitors, the gliptins, probably neutral, and I'll tuck into that a little bit. But the outlier here is the SGLT inhibitor story. So this is the first signal that maybe we can impact heart failure outcomes per se in a diabetic population. And I mentioned the EMPA-REG trial. I suspect most people are familiar with it, if not everybody. And this really got the conversation going in a big way. It was a surprise finding of a 2015 study where they're looking at cardiovascular safety, cardiovascular events in a diabetic trial. And these were 7,000 patients randomized to receive one of two doses of empagliflozin, an SGLT2 inhibitor, or placebo. And these patients had established cardiovascular disease. Only 10% of these patients had baseline heart failure, and the devil's always in the details, and unfortunately we don't have the details about what those patients were like with respect to their heart failure. And they had so-so diabetic control, and they could have so-so kidney function or better to get into the trial. And the staggering success, the headlines for this trial was that it was overwhelmingly positive. It reduced cardiovascular mortality, 3-point major adverse cardiovascular event reduction. So cardiovascular death, myocardial infarction, stroke. And this was something that was heralded as a big step forward. What was even more impressive was the heart failure-related outcomes. So although the study wasn't designed to answer the question, there was a clear early and continued separation of the survival curves with respect to heart failure hospitalization in the overall study population. And that applied to patients with a background history of heart failure, those 10%, and patients without a background history of heart failure. So this is a 35% reduction in heart failure hospitalization taking an oral hypoglycemic. And those who prescribed it are familiar with this class of drugs. Basically, these drugs cause a bit of a diuretic effect because they inhibit renal, proximal tubule absorption of a little bit of sodium and a lot of glucose. And so you get a relative hypovolemic state or volume contracted state potentially. And then the canagliflozin story, which is a competing agent of the same class. In the Canvas trial that was published a couple of years later, almost an identical clinical trial population enrolled in the study, almost identical size, I believe, and the outcomes were similar in that in the canagliflozin arm, patients had a similar magnitude of reduction in heart failure hospitalization. This study, the agent in this study, canagliflozin, did not seem to reduce overall adverse cardiovascular events and macrovascular events, but it did certainly with heart failure events. And this is the slide showing the discrepant results from heart failure outcomes and non-heart failure cardiovascular outcomes. So you put it together, the curves look nearly identical with similar magnitude of reduction, and about 10 to 15% of patients in these trials total had heart failure at baseline. So that's all we got, and so you have to decide what to do with this information as a heart failure cardiologist when we're trying to craft a guideline or look after the patients in front of us and interact with our colleagues in internal medicine and family practice. So it's definitely worth tucking into the details to the extent possible. The question, anytime you have a new drug, whether it's an ACE inhibitor or an SGLT2 inhibitor, is this a class effect or specific to the drugs? Of course, a question worth asking. The DECLARE study was released a few months ago, and this was 17,000 patients, twice the size of the other trials I showed you. And in DECLARE, there was a similar magnitude reduction in heart failure hospitalization in a similarly at-risk patient population. Again, only 10% of these patients had heart failure at baseline. And like the CANVAS trial, dapagliflozin didn't seem to reduce other macrovascular complications or didn't reduce the rate of stroke and myocardial infarction or cardiovascular mortality overall. But again, the heart failure signal is the same, which tells most people, I think, that, or convinces most people, this is probably a class effect of these drugs. And then very quickly on the heels of the EMPA-REG study, registries started to spring up. So the CVD Real registry looked at international uptake of SGLT inhibitors in a propensity matched cohort type study, comparing these drugs with other oral hypoglycemic drugs on heart failure outcomes. And again, this is 300,000 patients. You can definitely get a signal with a population that big. And that shows an unequivocal reduction in heart failure hospitalizations up to 40% or 39% when you're looking at the countries involved in the study. So I think very convincing evidence, such as it is, that we can prevent heart failure or reduce heart failure exacerbation at least. So what about the DPP-4 inhibitors? Not so clear. So the three landmark trials that looked at three different agents had somewhat discrepant results. And there have been some really carefully done meta-analyses. Dr. Verma, Subodh Verma actually, was here before in the prior session, published a nice systematic review in CME recently that tried to answer this question, looking at the totality of data beyond the landmark clinical trials. And the bottom line is nobody really knows if these drugs are beneficial, harmful, neutral, or whether there are differences between the agents within the class. The outlier, at least in the randomized control trials, is the saxagliptin based on the SABRE study. And that showed an increase, a statistically significant 25-26% increase in heart failure admissions in patients taking saxagliptin. When you see this in a clinical trial, then people go back to mechanisms and try to figure out why that might be. And when you read review articles and talk to scientists that study this, it's the same kind of arrows everywhere, and you just don't know what pathway is potentially responsible for this. But it's thought that this these drugs might create a sodium avid state in the kidney. And then the newer players, the GLP-1 agonists. So liraglutide is sort of the often touted success in this class because it was the first drug in its class in the LEADER study to show improvement in cardiovascular mortality. And that was driven by non-heart failure events. So we've got a drug that seems to impact cardiovascular mortality in a big way by reducing myocardial infarction and potentially stroke. But it doesn't seem to impact heart failure. It seems to be neutral with respect to heart failure outcomes. So promising, and if you have a patient with diabetes and you're looking at net risk reduction, this is a wonderful tool in the armamentarium. But if you're a heart failure specialist, this doesn't move the needle a whole lot. So how do you synthesize all that information, get a group of primarily non-experts, what I mean by that is cardiologists and not diabetologists, in a room to agree on what the evidence is telling us. And I think the first thing that has been landed on, and I remember these discussions well, is that we strongly agree that the experts should dictate how we achieve glycemic control. So the Canadian Diabetes Association guidelines are really well done. They're user friendly for the most part, And then we go on to say that the use of empagliflozin as an SGLT2 inhibitor has the strongest evidence, such as it is, to prevent heart failure outcomes. And that's a weak recommendation because we're talking about a surprise finding in a subgroup of a landmark study. But that's kind of the best we've got. I think the key word, though, is prevention. This is not necessarily a treatment for heart failure, but preventative therapy to prevent heart failure hospitalization. What do the Canadian Diabetes Association guidelines say? Well, they say that you would treat patients with diabetes the same as those without diabetes if they have heart failure. Metformin is recommended as first-line therapy. If the GFR is impaired at all, then consider cautious use of renin-angiotensin-aldosterone blockade. Consider dose reductions in appropriate circumstances. Do not use TZDs, the rosiglitazone type drugs, because of the clear association in a number of analyses with worsening fluid retention and heart failure. And avoid saxagliptin because of the study that I showed you, showing an increase, 25% increase in worsening heart failure with that particular agent. Sorry, these are not pretty slides, but they contain some text. But the bottom line is from the diabetes group in terms of recommendation is they say guidelines should be harmonized. We would agree with the Canadian Cardiovascular Society's guideline approach to managing heart failure, and that patients who have established cardiovascular disease or are at high risk should be considered for an SGLT2 inhibitor to reduce the risk of heart failure, essentially saying the same thing that the heart failure guidelines had said. There's nothing worse than having discrepant guidelines, confusing the message or mixing up the message, and I think that's one of the successes of what Sheldon Tobe has done with the C-Change program. So just finish off in a few minutes talking about how we might apply this to practice and trying to be practical along the way. So just for your consideration, another base case of a 70-year-old female with ischemic cardiomyopathy. Ejection fraction is right at 40%. She's got class 2 symptoms, and you know, class 2 symptoms matter as opposed to class 3 symptoms, because these are patients that come to your office and say, I feel good now. I didn't before when I was in hospital, but I'm good. Like I can do most of the things I want to do. And therein is the threat of therapeutic nihilism. But she's got diabetes for 10 years, hypertension and dyslipidemia, preserved kidney functions, not great glycemic control, not abysmal either. Blood pressure is 114, which is good for a heart failure patient. These are her medications. So aspirin and a statin, sure. Diuretic, sure. Metformin, sure. She's on an ACE inhibitor, a beta blocker, and a mineralocorticoid antagonist with spironolactone. So this is a well-treated patient with class 2 symptoms and this background story. So the question for you to consider is what's your next step with this patient? And would you start one of the newer heart failure therapies, the sacubitril/valsartan or adavirbidine, two new powerful therapies to cut heart failure mortality and in reduced ejection fraction patients? Would you start an SGLT2 inhibitor to prevent worsening heart failure? Would you refer to an endocrinologist to make a decision about that? Would you refer to a heart failure specialist to make a decision about that? Sometimes you don't have ready access to heart failure specialists. In most environments, that's the internist or cardiologist, but maybe primary care physicians who have an interest in heart failure management. So I won't put anybody on the spot or get you to commit to an answer, but these are things that should percolate as potential options. When I do present cases like this, when you see somebody with minimal symptoms, one option I always throw in was do nothing, because this patient's happy with their care so far. And most of the hands go up for that, or most of the clickers vote for that one, because it's very tempting to say someone's feeling well, they're on pretty good stuff. We're not going to chip away at the margins to improve things further if they're happy and go through the whole risk of worsening side effects. But I would say that the mildly symptomatic patients have a really bad long-term prognosis and tend to benefit more in terms of life years gained with interventions than the sickest of the sick heart failure patients, who are often palliative, and you're just changing the trajectory of their death.
Maybe that I'm asking the question, when did we decide to put that patient on the mineralocorticoid agonist?
Yeah, so good question. So this patient has reduced ejection fraction and mild symptoms. So the backbone therapy is an ACE inhibitor and a beta blocker. But a handful of years ago, there was a very well done study called the Emphasis trial that looked at exactly these types of patients and put them on a mineralocorticoid antagonist, a Clarinone. And and there was a 25% mortality reduction over about 3 years. So again, you're treating patients that are only minimally symptomatic, but probably changing the trajectory of their illness.
I'm sorry, what is it about this patient? Is it the ejection fraction or is there symptomatology? What was it that made this patient that made it put her on trial?
Repeat the question, Mike. So
Oh, sorry, sorry, for the benefit of people who are watching off-site. So the question was, what is it about this patient that drove an indication for the spironolactone, or the mineralocorticoid antagonist? So that was the answer I gave about the Emphasis trial. And your follow-up, yes, it's the reduced ejection fraction. To make this more realistic, I probably could have made the ejection fraction 35% or 30%.
I was going to say that.
That's probably,
So
less equivocal.
yeah, for what it's worth and up to date, it is 35%
Yeah.
that they advise to initiate.
Yeah, and so, and I'll show you a guideline slide that is a real attempt to simplify all this, but yes, patients typically have a lower ejection fraction. But the point I was hoping to get across is that this patient has only mild symptoms, and hopefully people would still chip away at this patient.
So Mike, I think there's an important point you made that Dr. Van Loon is alluded to. That patient might well have had, you can repeat, the patient might well have had an ejection fraction of 33% 2 years ago when these therapies were initiated. And would you withdraw spironolactone now because the ejection fraction is over 35?
Yeah, awesome question. So the question was, this patient may have started out with a lower ejection fraction, and when you start beta blockers and ACE inhibitors, you expect a modest but upward trend in the ejection fraction. Same thing with spironolactone. And now that the ejection fraction has reached a better threshold, 40%, would you start peeling back therapy? So a couple of, one critical point is this comes up a lot, especially amongst patients who don't like taking pills, which is like a lot of patients. We used to suppose, based on observational studies, that withdrawing medications in a recovered ejection fraction population, this is a new hot topic, recovered EF patients, which is the scenario being described. We used to suppose that with peeling back medications would lead to bad outcomes based on some small observational studies. Now we know that to be true. So we were right, because there's some recent randomized control data, small patient numbers, but in the group of patients who actually were randomized to withdrawal of medications for recovered EF, there were staggering rates of subsequent fall in ejection fraction and heart failure. So when patients come in, as they do, and ask if they can come off these medications, that's sort of a no-fly zone for us, and there's some aggressive counseling that goes on there. But it comes up a lot. So yes.
Does it matter the mechanism of the heart failure in the first place when you go to withdraw?
Yeah, so another really good question. And does it matter the cause or mechanism of heart failure when you're considering withdrawal? And there are occasional scenarios where yes, I think it's fair. Somebody comes in with uncontrolled tachycardia, atrial fibrillation, and the ejection fraction was normal. You've documented that it's really dropped, and now you're documenting that on therapy, you've controlled the heart rate and dealt with the atrial fibrillation, the heart function is better, then it makes, in that scenario, you've got a pretty clear cause, effect, and a little bit of a level of comfort that they're not going to fall apart totally. You recognize that they're vulnerable, and probably always will be from a heart failure point of view, but you don't expect them to totally fall apart. But those are the exceptions and not the rule. The rule is if you've got a bad pump, and we don't exactly know how you got there, which is the case in most non-ischemic cardiomyopathy patients, that you're in dangerous territory by withdrawing therapy. The other point is that at a population level, if you start with a low ejection fraction and push at these medications, Overall, there seems to be a net improvement such that about a quarter to a third of patients will go from reduced to preserved ejection fraction or have some partial recovery of their heart function over time. That's sort of population level data. So that all is kind of good segues into my next couple of slides. So I suspect the answer to that little scenario I gave, if you asked most cardiologists these days, would be thinking about adding one of the newer agents like ivabradine to slow the sinus rate down, or substitute the ACE inhibitor for sacubitril/valsartan, which is an angiotensin receptor neprilysin inhibitor combination drug that's been around for just about 4 years now. And that's because this has had a staggering impact on mortality over and above background ACE inhibitor therapy. So this is a massive victory for drug treatment and heart failure a few years ago, and it's been all the hype in cardiology circles. So I think most cardiologists think this way, and that feeds into the current guideline recommendations. So although this might be an oversimplification, I think simple is good because it helps most people most of the time. But one way to simplify heart failure management if you have reduced ejection fraction, EF less than 40%, is to make sure they're on so-called triple therapy: an ACE inhibitor, a beta blocker, and a mineralocorticoid antagonist, spironolactone or eplerenone, and then reassess the symptoms. If the patients are still disabled, many and most probably are, if patients still have heart failure symptoms, then you consider switching the ACE inhibitor for sacubitril/valsartan. If their heart rate is still elevated, more than 70 or 75 beats a minute, consider adding ivabradine to manage symptoms and improve heart failure outcomes. And then the flow chart goes further to say, if you still have symptoms after that, then you're into referring patients for either advanced therapies or palliative care, transplant, device therapies. Consider pacemaker support in some populations with left bundle branch block. So you're getting into the domain of more subspecialty medicine, but there's a whole lot you can do for most people before you ever get that far. And nowhere on this algorithm yet is looking at managing subgroups with diabetes with oral hypoglycemics like SGLT inhibitors. I think when we look at what the endocrinologists tell us, they take a more holistic view of their diabetic patients. They're going to look at optimal glycemic control, which of course is tailored to their risk and age, optimal blood pressure control, cholesterol control, drugs to protect the heart, so ACE inhibitors, statins, aspirin if indicated. I know that's another hot topic. SGLT2 inhibitors or GLP agonists if they have demonstrated cardiovascular protective benefits. Exercise, smoking cessation, self-care. In terms of the scope or the magnitude of benefit with some of these newer diabetic agents, they really plot well with the same kind of interventions that are life-saving therapies for heart failure patients. So if you go back to the ACE inhibitor trials and the angiotensin receptor blocker trials, beta blocker trials, these have really a big impact in relative risk reduction in terms of mortality. The empagliflozin and the liraglutide, which is a GLP agonist, has a similar reduction in mortality. It's not all heart failure mortality, but it's a reduction in mortality in a similarly at-risk patient population. So these are big players. So should we use or not use something like an SGLT2 inhibitor in all patients with diabetes? So arguments for, arguments against, and again, this is a slide from John Howlett, and I think the arguments for are that the data is consistent. Multiple studies have confirmed the same findings, and this is consistent across different levels of risk, and it reduces total mortality. So those are pretty compelling arguments on the surface. The arguments against are equally intelligent. They're equally valid. We don't know the mechanism of action. The trials weren't designed to answer these questions specifically. They weren't heart failure trials. And their event rates were lower than you would expect if this was a real heart failure population. And it just speaks to the fact that patients with heart failure in these studies were not well characterized. So with or without pre-existing heart failure in the EMPA-REG trial, similar magnitude of reduction in heart failure outcomes. But when you look at even patients with baseline heart failure, these 10 to 12% event rates, that's much lower over event rates, I mean heart failure hospitalization. That's far lower by about half of what you would see in a heart failure study. So in a heart failure study, you'd probably have at least a third to 50% higher rates of heart failure admissions if in a typical heart failure population. So you're probably comparing apples to oranges a little bit. And so the question, though, is going to be answered. I think there's some really exciting trials that are going to come out that will change practice one way or another, or at least change our thinking. So there are heart failure trials. These are not diabetes trials. So these are broad spectrum of patients with heart failure randomized to placebo or an SGLT inhibitor. There's the DAPA-HF, the Emperor Reduced, Emperor Preserved studies. So we're going to look at thousands of patients with or without diabetes, placebo versus these drugs, to see if they improve heart failure outcomes and cardiovascular death. So that's going to be potentially game-changing if you're anywhere near positive, particularly for the preserved ejection fraction patients for whom we have almost no therapies that change the natural history of their illness. So one of the things, this is the same algorithm I showed earlier, but I've added, maybe I'll use the little pencil notes here. What I've said is that maybe we'll actually in 3 or 4 or 5 years be saying that while you're modifying the disease substrate, you have to think about managing their volume status with SGLT inhibitors instead of or in conjunction with diuretics as standard of care therapy. Now, that's just one prediction. It might be completely wrong, but at least we have the studies that are going to answer the question. And so some practical tips just to finish off. I think when we're managing comorbidities in heart failure, something that cardiologists probably don't do as well because we're cardiologists and we tend to think of one organ rather than all of them, but we do recognize that our patients come with a lot of comorbidities, and it requires a little bit more heavy lifting with respect to their medication adherence, monitoring their other disease parameters, and we have to be flexible and responsive to changes and intercurrent changes in health status. Again, practical recommendations from the Canadian Diabetes Association. So metformin first line unless absolutely contraindicated, but metformin should probably be withheld or even stopped in patients with an irreversible decline in kidney function. And again, in patients with diabetes and heart failure, many of whom have comorbid chronic kidney disease, upwards of a third or more, we're really looking at starting low and going slow when we're looking at renin-angiotensin-aldosterone blockade. Dose titration should be more cautious and more attention paid to weight and electrolytes within a week or so of making any changes. There's a lot of discussion about what to do with diuretics and SGLT inhibitors. Nobody really knows, but I think it highlights that caution is required. If you have a hypovolemic or volume contracted patient, you may want to stop the diuretic when starting an SGLT inhibitor. If you have hypervolemia or fluid overloaded, like many heart failure patients are, then you're okay with both perhaps, but you want to keep a close eye on things. And of course, entering into that matrix is what's their blood pressure. These drugs cause a lot of orthostatic changes, and you have to be very mindful of what blood pressure is doing. And the hypotensive patient may have to stop the diuretic. And this is my second last slide. I'm not sure if someone's going to talk about this at all, but what's come on our radar is that because you've got comorbid population at risk for intercurrent illness, anything that threatens renal function should prompt an adjustment in these commonly prescribed medications, including the SGLT inhibitors, non-steroidals, angiotensin receptor blockers, ACE inhibitors, diuretics, metformin, and sulfonylurea. So that actually, not in the order I said, but that actually says SAD MANS, and I think that's a nifty way of just paying attention to the details when patients are sick. So in summary, I think diabetes is prevalent in heart failure patients, and heart failure is actually very prevalent in the general diabetic population. And clearly that's a toxic interaction, that diabetes unequivocally confers a worse prognosis in patients with heart failure. and that newer agents impact cardiovascular outcomes, probably unrelated to glycemic control, but we don't know the exact mechanism. And the biggest benefit we're seeing in heart failure is reduction in heart failure hospitalizations in an at-risk population. And then I think there's ongoing trials, the ones we just mentioned, that will really clarify the role of these drugs in a broader spectrum of heart failure patients, and which means that cardiologists who see heart failure as 90% of their practice are really going to have to scale up with these new drugs and understand their nuances, and there are nuances for those who are familiar with prescribing them. And then I think newer heart failure therapies mean more complexity. There's just more than there used to be in the last decade, and will be. There are other heart failure therapies coming down the pipeline in phase 3 trials, some of which will likely be positive studies. And I think that is going to be more heavy lifting, and where that's going to happen or have to happen is organization of care, linking specialists and primary care and other subspecialists together, tightening up communication at all levels, delineating roles, and figuring out creative models to keep these patients out of hospitals. So I think it's a tough condition with a better outlook now than it did decades ago, but these patients are no question require a lot of heavy lifting and creative thinking. So I will end there and take some questions. Thanks very much.
Thanks for that great presentation. So those of you on the web, please send in your questions. Don will be watching for them. Did Shrinu make it?
No, so far.
Okay. So I'm going to ask the first couple questions. If you had a patient who had an A1C of 5.6 and didn't have heart failure, or did, would you start SGLT2 inhibition? And the corollary to that is, would you take something away, like glycoside, in order so that the A1C came up so you could start SGLT2 inhibition?
Yeah, no, I don't think so. I think
Just a little closer.
yeah, in somebody, so I think everyone heard the question, but for the first answer is that I don't know. I'm still very much finding my way with these new drugs, just like many of my colleagues. And in a patient without established or known benefit, someone with good glycemic control, I don't think it makes sense to worsen their glycemic control to then start a new medication. That doesn't seem like we should do that. But so the short answer to your question is no. But I think once we get a little bit more familiarity with the drugs, comfort with the drugs, and clinical trial evidence, we'll have a better handle what we ought to do.
Okay, Dr. Dallaire?
Sorry, so actually I had a question I was going to ask earlier, but on the same vein, what if someone has someone with heart failure being properly treated and then develops type 2 diabetes, say A1C of 7.3? Can you start the first line in SGLT2 instead of going with metformin?
So the question was, if someone develops diabetes with heart failure, which happens a lot, some people say that heart failure is a diabetogenic condition, should you use an SGLT inhibitor as first-line therapy? So it's very tempting to say yes, but that's not what the experts who write the diabetes guidelines would have us do. And so I'd have a lot of deference to what they would recommend, but it may be a different story in 5 years or 10 years from now. So tempting, but I don't think we can do that yet.
I'm just
Nasser?
addressing what did you say? If the A1C is 5.6, we know glycemic control does not really change the outcome, right? The microbiological microscopic changes you have there, it doesn't really affect. So why don't we start when we know where the direction of the patient is going? Why don't we start? Why do we wait till, say, the sugar goes up and A1C goes to 6 or 7? There's no reason not to start it.
Yeah, so the question was, there's no reason not to start it in somebody with diabetes who has excellent control. It's a good question. Studies haven't answered that question, haven't been designed that way. So we're dealing with an unknown. So you're dealing with what's logical and biologically plausible weighed against what does the evidence actually tell us. And so, it depends on how you model your practice. But I think most people, wait for the evidence to tell them what we hope, because you can get burned the other way as well. Again, the drugs are not totally innocuous.
When are these trials going to be come out?
I think the trials, the question was, when are these trials going to come out? I think they're 3 to 5 years from now. I don't know the exact reporting date for them.
Don, do you want to just check and see if there's anything coming in on inbound here?
You bet.
So can I just make a,
Yep. Mike?
one question for you, Mike, which I think is a good one. As cardiologists, I struggle with this. When all things being equal, you've got a diabetic who comes in who is at risk, let's say. You're worried, but they've not micronal infarction, and they've not necessarily had a heart failure thing. But maybe you think, they've got let's just say that they don't have, they're high risk. Would you preferentially choose an SGLT2 or a GLP-1? What would your preference be?
So again, the question is, what's your preference if you've got an at-risk patient without an incident heart failure or myocardial infarction event? Do you choose the GLP-1 versus the SGLT inhibitors? Well, that's a great question. I don't know the answer. I mean, it all sounds attractive. I mean, in the real world, it's a phone call to my endocrinology friends saying, "What do you think?" And I think the patient adherence. I think there are different factors in the soup that the endocrinologists have a much better handle on than I do, because they see this all day, every day, and this is their world.
Yeah, the other thing I was going to make was a plot. So we are here doing Emperor Reserve, we're doing Emperor Reduced, we're doing DAPA HF. So we're involved in all three of the trials. So if you have anybody who you think would like to get engaged, let us know. Just send them right over. We'll be happy to get them involved. Emperor Reduced is enrolling at a very rapid pace. And actually, we're hopeful that we'll see some data for Emperor Reduced probably late 2020, maybe 2021.
Yeah. Awesome. Yeah.
So, so we do have a question from the web. This question from Kingston, and it is, why not skip ACRB and just start with Entresto?
Yeah. So a question we get asked a lot, especially by the makers of Entresto.
Why would they ask that?
Yeah, and it's actually a very legitimate question, but again, it comes down to the way studies were designed to inform the evidence, and as people get comfortable with these new drugs, then there's indication creep. In other words, using them the way they weren't initially studied, but that might still be okay. And I think you have to highly individualize that. The particular concern with sacubitril valsartan is it's not tolerated by about 15% of people. In the study, you had to tolerate the drug for 2 weeks before you could be randomized to taking it for longer than that. So, the dropout rates for some of these drugs are real, and it's because of very potent antihypertensives, and so you're not sure if everybody's going to tolerate it, whether that's the right thing to do. Again, I think in a few years we'll have more clarity around that. We never used to start the drug in patients in the inpatient setting, and now there's some data that says, yeah, that's probably okay to do. You're going to have more heart failure related benefit by starting the drug before patients leave hospital, and don't wait till they come back into the ambulatory setting to do this. So the indications are moving, but I think we're trying to be rigorous with how we interpret the evidence such as it is.
Just make the comment, a sidebar comment, that the same is true of Aberdeen, isn't it?
Yeah.
Jonathan was talking about that in-hospital starting of Aberdeen in patients in whom you can't get rate control confers a pretty early benefit. So I think probably 6 or 12 months from now, we won't be having this discussion. We'll just be doing it.
Yeah.
That's what's going to happen. But anyway, anybody else in the room? Elliot?
Could you comment on the value of iron therapy in heart failure? There's a growing body of evidence supporting its use, and in the renal world, the recent RCT trial showed reduced heart failure, MI, and death with pushing iron levels in dialysis patients.
Yep. So great question. Related to iron and heart failure patients. So It's a good therapy. So first of all, a lot of heart failure patients are iron deficient, and that's irrespective of whether they're anemic or not. So patients can walk around with normal range hemoglobins and be massively iron deficient, and unless you look for it, you won't find it. And there are some studies, some moderate-sized studies, that show an improvement an unequivocal improvement in quality of life in patients with reduced ejection fraction, preserved ejection fraction with IV iron. There have been some small studies with iron tablets. Everyone thinks we'll just take oral iron. It's a lot more convenient, but it doesn't seem to have the same benefits. And whether that's just because it's less effective to replete iron stores is unknown. But what we do know is that IV iron therapy makes people feel better. So we've started screening just about all of our patients for iron deficiency in clinic, and we have a day unit such that if they are iron deficient, they get a phone call, and a nurse will bring them in, and they'll get their bag of iron for 3 doses over about 6 weeks. And I must say, that's been a little quality improvement initiative in our own heart function program, and patients really do come back feeling better. And maybe it's just a massive placebo effect, but the data supports it, and patients really tell you they feel better after a bag of iron.
Judith?
If they have a normal hemoglobin, you can't get the IV iron.
Like, I think the data shows that it's probably that it affects mitochondrial function, so that the effect is totally independent of your hemoglobin.
Or for us ordering it?
No, so Judith's question has to do with, can you actually order IV iron for a patient with normal hemoglobin?
No.
That might be something that institutions have to reevaluate.
Yeah, I didn't know, hadn't heard that as a problem, but yeah.
Outside of a heart failure clinic, it may be a problem.
Yeah, we do it. I don't know. Something happens.
You order it, it happens.
Yeah.
Dave?
And at what level are you considering this replacement?
Repeat.
What level are you considering someone iron deficient? So,
No, at what level are you considering
replacing iron?
Supplementing it.
Supplementing. Yeah, no. I'm just trying to remember. I think it's a ferritin less than 100 or less than 200 with an iron saturation less than 20, something like that. I have to look at our little table. Yeah, someone said everyone on the planet, but yes, when you look for this, it's remarkable how iron deficient our patients are.
Judith, supplement?
Yeah, so if you have a patient who has pristine LDL, non-smoker, blood pressure is perfect, and they're doing everything, they're on their statin, everything's perfect, diabetic, hemoglobin A1C is that target, and you put them on if you put them on a GLP-1, what's the advantage over all those other things that you're doing as far as cardiovascular?
Yeah. So it's a great question. So what is the additive benefit of a GLP-1 agonist in reducing cardiovascular outcomes in patients who are well treated with target risk factors controlled? And the answer is I don't know. I think you'd have to go back to the studies and figure out how many of those patients actually had good control of their risk factors. I suspect a very small proportion. And it does raise a good question. I have no idea. But what I think it does is so many patients are on other diabetic drugs that probably have neutral, even harmful effects on macrovascular outcomes. So maybe you have to think about, what's better rather than am I doing something good right now. But it's a good question. I don't know the answer.
Question,
Yeah. Hard to know. But I think what these newer agents reveal is there's probably a better way of doing things than there was 10 years ago.
Okay, one last question in-house. See if anybody's on the web. One more for you. Okay, so one more question from Kingston. Mike, this is going to be a good one for you. So the question has to do with the relative lack of efficacy of what we do for heart failure with preserved ejection fraction. Should we throw in the towel, shoot ourselves in the head? What should we do?
Yeah, no. Some days, but yeah. So most people, when you hearing heart failure talks, try to avoid the topic of heart failure with preserved ejection fraction because you got nothing to say. The truth is that's about 40 or 50% of the overall heart failure population. They're older, they're comorbid, and there's been spectacular failures or non-successes of a lot of trials, ACE inhibitor trials, angiotensin receptor blocker trials, signal of partial success with mineralocorticoids. Remote monitoring seems to help in some patients with preserved ejection fraction. Iron replacement for iron deficient preserved ejection fraction works. Heart function clinics work for preserved EF patients. But it's hard to know what intervention seems to benefit. And the way I think of it, because I do think about this a lot, the way I think of it is that, the heart failure with low EF patients, EF is less than 40%. Those patients are quite likely going to die from cardiovascular causes. They're going to die suddenly from arrhythmia, or they're going to die from progressive heart failure with end organ dysfunction. If you have preserved EF patients, they tend to be older, they tend to have a lot more comorbidities, and they don't necessarily die heart failure related death or arrhythmia death. They die from cancer, COPD, renal dysfunction, stroke. And so it's hard to design a drug as an intervention that's going to impact all of those things. So that's why the condition is so maddening, because you're dealing with a cardiac syndrome that you can palliate, but you can't turn time back and prevent them from getting where they got. So it's a completely maddening thing to deal with. There are some big trials like the Emperor Preserve study that you're doing here with empagliflozin. There's a study with sacubitril valsartan in the preserved EF patients. Everybody's got high hopes that these drugs are going to change the natural history of the disease, but I think people are getting more and more cynical. But I think you have to change the way we're thinking about what the disease actually is. So that's sort of a capsule of a whole lot of introspection that most of us do.
Thank you.
Okay.
So I'm just going to, before people sign off on the web, just a reminder that 2 weeks from now, Chris Simpson's here, Cannabis in the Heart. And for those of you who weren't in the room 2 weeks ago, you didn't know that dancing actually broke out here almost spontaneously after the last session. So we're going to see if we can get the Weber brothers back and maybe some other musicians for the final session with Dr. Matangi. The handout that we have circulated is something that we'd like to get feedback from you on, whether you think that it might be helpful in your practice to have a guide for your nurses, your other staff to take a look at the patients, try to optimize heart failure therapies. If you'd like us to work with you on your EMRs to query who is not optimized, we'd be glad to try and help you with that. And if you'd like us to provide an electronic version of the flow sheet that you could incorporate into your EMRs, then we would be happy to try to work with you on that as well. So with that, I want to thank Dr. MacDonald for having presented a very, very stimulating talk here tonight. I think anybody who wasn't worried about heart failure and diabetes certainly is now. Hopefully we can all work together through the guidance of people like Heather Ross and Mike MacDonald. And by the way, they both come here for our advanced heart failure clinic here to orthocardiology periodically. So we're very, very fortunate to have that resource. So we thank you for your terrific talk tonight, and we look forward to working with you.
Thanks very much.
Shut down. Okay.